I think that hip replacements are generally considered when patients or individuals are not able to cope with the pain that they have coming from their hip anymore. Usually this is after the hip's been worn away, either by sort of degenerative changes, that's osteoarthritis or other forms of arthritis, or even trauma. But I always say to people that we treat people, we don't treat X-rays, and therefore looking at an X-ray and saying that your hip's worn is only one part of the whole picture. I think when people are able to still cope with the activities of daily living and the sort of activities they want to do, then we should sort of aid them to do that. I think once the pain that's coming from the hip stops them from doing all of that, and that's where a hip replacement can come in to get them back to the level of activity that they would like, and of course get them out of pain as well. The first thing to say is a hip replacement is always performed under an anaesthetic. The most common form of anaesthetic that we use in this country is a spinal anaesthetic. That's an injection in the back, and that's because it generally patients recover more quickly afterwards. Generally, the patients are on their side, and we go through the layers of skin and fat, getting down to the joint, and replace both the ball as well as socket components of the hip with artificial components. In terms of risks, hip replacements are a big surgery. It is big surgery. There's no doubting that. It's very successful surgery, however, but any big surgery has risks, and that's general risk of bleeding, infection, or damaging those arteries and veins, or indeed clots. And then there are more specific risks to hip replacements, things like the one limb being slightly longer or shorter than the other, or the ball coming out of the socket. The important thing to say is these risks don't happen often. Mostly they're around about the 1 to 2% mark. And long term, the survivorship of hip replacements is extremely good. That usually reassures people that I operate. So this is a question I get asked quite frequently. The truth is, hip replacements are made of multiple materials. That's any hip replacement perform. There are specifics to do with the form of hip replacements that a specific surgeon might use to tailor a hip to that specific patient. But mostly I use an uncemented hip replacement. That's to say that both sides there isn't an extra material that's involved in the bonding with the components of the bone, and the component that goes in the thigh bone is made of titanium, and the small head is either made of a cobalt chromium alloy or a ceramic. On the socket side of things, it's a high density polyethylene, which is a type of plastic, and finally a titanium shell. Most of the hip replacements I perform rely on an initial sort of fixation where the components are wedged in, but then long term the patient's body actually grows into the components to incorporate. That is the majority of hip replacements that I perform. I think with regards to side effects, it's important to split things into the anesthetic side effects and the surgical side effects. I think a lot of the medications naturally that are given from the anesthetic can cause some post-operative nausea, vomiting, or to cause people to feel lightheaded. Truth be told, the anaesthetists are very good at predicting this and preempting it, and also counteracting it with appropriate medication. From the point of view of the the operation itself, I wouldn't say there are specific side effects to actually having a hip replacement in, but to put the hip replacement in, clearly it is surgery. There's a certain amount of blood loss and other risks that we've spoken about to expect. But usually people are very well. But usually people do extremely well and don't have very much in the way of issues, and are able to actually start their rehabilitation process either the same day or the day afterwards. This is a question I get asked a lot, and I think the truth is it depends on what the specific activities that the patient is trying to get back to. I think most of my patients that I see back at roughly the 6-week mark are usually mobilizing fairly pain-free with minimal assistance, and are able to certainly start going through going back to their activities of normal living. And by 3 months, this is the case for most people. But there's no hard and fast rules. I say to people, you recover at your own pace. So for some people, it's much quicker than that. Some people, it's a little bit slower. It's the destination that matters.